everyone in the room and indeed everyone online. My name is Graham Slight. I'm the chair of the Science Fiction Foundation, and I'm so pleased to welcome you to this year's George Hay Lecture. Many of you will know, but it bears repeating, George Hay was one of the SFF's founders back in the 1970s, and he very passionately believed that science fiction and science should not happen in isolation from each other. And so for the last several decades, we've sponsored these lectures at Eastercons and elsewhere. And I just want, while I'm here, to thank the team at Levitation for their continued support of the George Hay Lecture. I am especially pleased this year to welcome Dr. James Flanagan, our lecturer this year. He is an extremely distinguished researcher in the genetics of cancer, as I think we're about to hear. In addition, and very relevantly to today, he is also an author of fiction. You may be able to see Gene Fire just sitting on the stand behind me, and I think he will happily sell you a copy in the dealer's room, or indeed happily acknowledge if you buy it on Kindle. But I'm looking forward to a really interesting and topical lecture from Dr. Flanagan on battling cancer in 2024 and beyond. Dr. Flanagan.
Thank you. So it might have been a slip of a tongue, but Battering Cancer is also a very good title, especially when we're treating it. I think those that have been through cancer will feel like you're battering it with chemotherapy. But yeah, the title of this lecture is Battling Cancer in 2024 and Beyond. Well, first of all, thank you for inviting me to give this lecture. It really is a pleasure. This is my first time at Eastercon. It's my first time at a science fiction con in general. It's also my first novel published, so a lot of firsts here. Right, so what are we going to talk about today? I'm going to give you an overview. I'm going to give you the big picture. How do we picture cancer these days? How do scientists look at cancer? How do patients think about cancer? I'm going to then talk about a couple of topics that are of interest to me. My particular area of research is around risk and prevention. That's what I've been working on for the last 15 years or so. Early diagnosis, this is probably one of the key things that we can do to improve cancer outcomes. And I'll talk a little bit about my research in this area and also a little bit about, I guess, what the big thing is happening in this area. And then at the end, I'll talk about better treatments and better outcomes. And then finally, at the end, I'm going to sort of cast my eyes into the future and give you a glimpse of some of the things that might be coming up that will help us in this fight against cancer. So, a bit of background on myself. So, a long time ago, in a country far, far away, you may or may not have already told or figured out that I'm from Australia. My accent's probably changed a little bit. I have been living in London for nearly 20 years. But yeah, I grew up in Brisbane and I did an undergraduate degree in medical science at the Queensland University of Technology. Oh, that's not the right button. Go back. And then I did my PhD at the University of Queensland. In my PhD, I studied viral oncology and how viruses cause cancer. I then moved to, once you finished your PhD, as we advise most of our students these days, if you go on to an academic career, you go and do a postdoc somewhere. And the best thing about being a postdoc is you get to travel around the world, because you can be a postdoc anywhere. And I used this opportunity to move to Canada, mostly because I wanted to learn how to snowboard, but also to learn about this new field of research called epigenetics. I'm not going to talk too much about epigenetics today, but it might come up. So I went to Toronto to learn about that, because that was a really big field, or it was really new in around about 2004 when I was studying it. I then met my wife there, or soon-to-be wife there, and we moved to London. And I was a postdoc at UCL for a few years before I then was awarded a fellowship from a charity called Breast Cancer Campaign. They're now called Breast Cancer Now. And I started my own research group in 2009 at Imperial College, and I've been there ever since. So let's start off. What is cancer? The first thing you need to know about cancer is it's common. At the moment, the statistics say 1 in 2 people is going to get cancer in their lifetime. That's quite a lot. You know, if you're sitting next to someone, you know, it's one of you two, basically. That's a really scary statistic, right? Now, if you happen to be sitting next to someone who's had cancer already, that doesn't mean you're off the hook, because cancer risk doesn't work that way. You're at a 50% risk in your lifetime of getting cancer. That's really scary. It's a lot of people. The second thing about cancer is it's nasty. It kills people a lot. And currently the statistics say that 1 in 2 people that are diagnosed with cancer will survive 10 years after their diagnosis. That's, you know, half. That's not a lot of people. And although there has been improvement in this, so if we go back to 1970, you can see this graphic just here. In 1970, that number was 1 in 4 cancer patients would live to 10 years after their diagnosis. It's now 1 in 2, 50%. We've made a lot of advances there. But there's also a lot of variation. I'm sure you're probably aware there are cancers like pancreatic cancer where the 10-year survival for that is 1%. That is a cancer that kills people really quickly, and it's really awful. There are other cancers like testicular cancer where the survival is now up to 98%. We've got some really great drugs for testicular cancer, some of which were discovered at Imperial College, by the way. The third thing is cancer is clever. So as a scientist, I look at this and I see that cancer is very clever in the way it adapts. And I use this quote here because it's something that really struck a chord with me. This was a conference that I went to, more than 10 years, 12 years ago now. And this is a big cancer conference in the UK. And there was a scientist there who said this: it took us 12 years to develop this cancer drug, this new drug. And it took cancer 12 weeks to figure out how to beat it. So they gave this drug to patients, and within 12 weeks, that cancer had already developed resistance to that drug. And that, to me, is a really sobering thought. It's like we spend a lot of money, you know, imagine how much money they spent developing that drug, and already it's useless in a way. So that, to me, is the real key problem and the challenge in treating cancers, is because it adapts. And we use this word heterogeneity, and that means that all the cancer cells are different. Not every single cancer cell in a tumour is the same. As it grows and as it divides, it picks up new mutations, and there are different subpopulations of cells. And then we hit it with a barrier of some sort. It's either surgery, we cut most of it out, or we hit it with drugs, with chemotherapy. Many of the cells die off, but some survive. Some get through that gateway. And those that get through then repopulate and redivide and change and develop a new heterogeneity that's adapted to that treatment that we've used. And that's why it's so challenging. And there's a lot of research going on trying to understand that heterogeneity and how to beat that. So just to use an illustration, this is cervical cancer, just to illustrate how cancer develops. It often starts as a small group of cells that have gone wrong, and they'll divide and they'll start expanding, and then they'll expand more and more, and then it's when they break through that basement membrane layer then it starts to invade. So you've got these initial cell changes, you've got the growth and expansion of the cells, and then it escapes and it metastasizes. And that's generally how cancers develop and spread. But how, as scientists, how do we understand it today? I'm going to go back to these two guys here. These are two sort of famous scientists, Hanahan and Weinberg, and they published this thing called the Hallmarks of Cancer. So this was back in 2000. Back when I was doing my PhD, so more than 20 years ago. And they came up with this concept that basically said every cancer cell needs to have all 6 of these features. It needs to be able to divide as much as it can. It needs to make its own blood vessels, so cancers get bigger and bigger, and eventually they're going to need nutrients, so they make their own blood vessels. That's how cancers sort of get bigger. They need to avoid dying. We give them signals to die, and they don't. It's a DIY growth signal, so they create their own growth signals. They ignore all the stop signals. All of the other cells around are telling that cell to stop growing, and it just needs to ignore them. And then it also needs to invade. It's only once it invades that it starts to spread and get bigger and then becomes a problem. So these guys came up with this concept, and a lot of people focused on it, and 10 years later they published an update. Well, not 10 years, sorry. We were expecting it 10 years later. It came 11 years later. It was a little bit late. But they've added a few new hallmarks, things that we think, these are really critical. We need to think about this. Inflammation, what's that one? Avoiding the immune system. So we started to recognise that the immune system is involved in cancer and we need to address that, and some various other things. The dots around outside of this are now where we're saying, all right, all of these pathways are important, and we've got drugs now that can target each and every one of these. So we're going to start exploring developing drugs that target all of these. But if we fast forward to today, or 2022, and another 11 years later, they published another update. I was very heartened to see this because they've finally recognised that epigenetics is an important hallmark of cancer. I kind of knew that back in 2000 when I was studying it, but it did take 20 years to get on the map, so to speak. They've also recognised this heterogeneity. This is what they call plasticity here. And some various other things. Microbiome is now recognised as a very important contributor to cancer development and also cancer treatment, by the way. So this is how we understand as a scientist, how we understand how cancers develop, and these are all the features that cancer cells need to acquire to become a cancer cell. But how do patients see cancer? So for a cancer patient, normally it starts with symptoms. You will start to notice an alarming symptom of some sort. And I've got here the 22 most common symptoms. Unexplained pain, that's quite vague. Unexplained weight loss, skin changes, moles, so that's obviously melanoma and things like that. You've got things like bloating is a very common symptom for ovarian cancer, for example, but again, it's a very vague symptom. Heartburn is one that you might not recognise as a cancer symptom, but for cancers like esophageal cancer, it's the number one symptom for this cancer type. So you'll think, oh, geez, that symptom's probably a bit too much. I better go to my GP. And you'll go to your GP and you'll get your appointment, or maybe more appointments, several appointments, perhaps before they eventually refer you to the cancer clinic. And this is where you get the extra tests and you'll get your final diagnosis. And it's that point where they decide your treatment. And that's going to be things like surgery, chemotherapy, or other drugs. Now, I've highlighted this here, 62 days, because it's kind of an important benchmark. And in the UK, in the NHS, they set that 62 days as a benchmark. We need to get our patients to treatment within 62 days of that GP referral. I just want to show you a graphic that's actually, to me, quite concerning. So this is, I'll just focus on the purple line here. So that dotted line is that 85% of patients. We want to see at least 85% of patients being treated within 62 days of that referral. The purple line here is what the actual rate is. So you see, we're doing pretty good here. We're meeting our targets, but then it starts to slips, and it's starting to fall down through the floor now. Now, it's fair to say COVID had a bit of a mark, that little blip there, that's COVID, but it's slipping even worse further down. So we're now down at a point where only 60% of patients are getting to their treatment within that 62-day window. Now, I'm sure there's somebody or some of you in the audience are thinking, the bloody Tories, it's all their fault because they came in around about here in 2010 and it's all going downhill since then. Now, I think it's maybe fair that they're a little bit contributing to this, but it's also, you've got to also think about how many cancer patients doctors are seeing these days. So 1 in 2 patients are being, 1 in 2 people are going to get cancer, and that's going to be all the referrals, all the treatment, all of the diagnostic tests, surgery, all of that is really common. I was thinking about this when I was putting these slides together, and I remember back in 2011 giving talks like this and telling everybody in the audience, 1 in 3 people are going to get cancer. It was only 10, 15 years ago that we were saying 1 in 3 people will get cancer, and we're now saying 1 in 2 will get cancer. So that means it's ramping up. We're getting more and more patients getting cancer. And so I think that's got a lot to do with that dip. But it is concerning, and it is something that we need to address. We need to get that back up above that line. And, 85% is even a fairly conservative target. Let's go for 90 or 95%, perhaps. Perhaps we can do that. And I think one of the main ways in which we can reduce that burden on the NHS, and this is why it's my focus in my research, is prevention. Prevention really is the best way to stop cancer. So that's what I'm going to talk about next. Risk and prevention. These are the most, well-established cancer-causing factors. Age. Obviously, we're getting older. That's what gets you cancer. Genetics, that obviously plays a big part. And I've been a bit naughty here. I didn't put the y-axis on this slide. These are proportionally what proportion of cancers are attributable to that risk factor. Genetics obviously plays a big part. Things like BRCA1 and BRCA2 mutations. If you've got a family history of cancer, there's a good chance you've got a mutation in a gene that's contributing to that risk. Smoking. Oh, go back. Smoking is probably the biggest modifiable risk factor. I'm going to talk a little bit about that again in a few slides. Excess body weight contributes. Alcohol, UV radiation, that is mostly for melanoma, skin cancers. And I will say, being from Australia, melanoma is obviously a much bigger deal in Australia than it is here. And there's a lot more campaign around slip, slop, slap and things like that. But in this country, the number one cause of melanoma, or that UV radiation, it's not the sun, I can tell you that much. It's UV beds, it's sunbeds. And it's a lot of young girls in particular using sunbeds, and that's what's increasing the rates of melanoma in this country. So I think, we should just ban sunbeds. It really is, there's no need for them. Poor diet, infections, HPV, I'm going to talk about that in a moment, and physical inactivity. All of these things contribute to your cancer risk. What doesn't cause cancer? I use this as an example. I don't know if you've ever seen the Daily Mail list of things that cause cancer. The problem is there's a nugget of truth in every one of these things. This is the list. Asbestos causes mesothelioma. That's true. Breastfeeding is actually protective for breast cancer. 2 different types of cheese. Cocaine, of course. Contraceptive pills, I'm going to talk about that in a little bit. It's protective as well. This list goes on and on. Yes, no, it's true though. There's a nugget of truth in that. HRT, I've talked to someone last night about that. Left-handedness, there's a good one. Anyone left-handed here? Mouthwash, morphine, pickles, poverty. Poverty is an interesting one, actually. There is a strong link, actually. But it's not causative. I'm going to talk about this last one, just because it's the last one we landed on, zebra toys. And this is, I guess, the problem with the Daily Mail. It'll pick up a news story. What happened was there was a particular toy, I think it was in the US, I can't remember if it was US or UK, where there was a product recall, because this particular zebra toy had a colouring dye used in it that contained a carcinogen. So there was a chemical on this toy that can cause cancer. And so there was a product recall. And obviously that made the news. If you had that toy, throw it out or get your money back. But nobody ever got cancer from that toy. It got recalled. And yet it's on the list as one of the things that cause cancer. And I think that's the lesson here, is that whatever you see in the news, you've got to be discerning. You've got to look into the data yourself. You can click through, usually these days, when you see these articles, they will have a link to the original study that was published. Click on that link and go and read it. You might not understand all of the abstract, but you might see the real data or the real conclusions that the scientists made on that work, and that will actually give you much more of an idea of what that finding is, rather than what you're reading in the news. So I think that's an important thing to remember. All right, I'm going to ask you all a question, and because I can't see everybody with these lights, I'm going to ask you, how are we going to prevent lung cancer?
Persuade people to quit smoking, first of all.
There you go. That's all it is. Sounds pretty simple, doesn't it? Stop smoking. If we got everybody to stop smoking, imagine what that would do. This is some data from looking at smoking rates in the UK versus lung cancer rates in the UK. And I'm just going to focus on the blue line to start with. That blue, so back in the 50s, 60% of males smoked. And you can see the lung cancer rates about 20 or 30 years later are pretty high. And, you know, around about 1970s, middle of the 70s, Richard Dole published his papers that said smoking causes cancer, and there's a steady decline. It didn't drop off a cliff, you know, it's just a steady decline. And lung cancer has been steadily declining with that. So that's a pretty easy graph to draw, you know, extend it out, and you can figure out when smoking stops, lung cancer will stop as well. Women, it's a little bit different. They started smoking a little bit later. There's a lot more smoking in, I guess, the 50s and 60s, and their lung cancer is just starting to peak and will hopefully come down again soon. If we did stop all the smoking, then that would cut out about 50,000 cancer cases in the UK per year. That's quite a lot of cancer cases. And I went and had a look at the numbers. That's going to cost, well, the treatment of those 50,000 patients is about £2.4 billion per year in the NHS. So imagine if we didn't have to treat those patients anymore, how much more money the NHS is going to have for other things. And I think that's the message that we need to sell. Stop smoking so that we can actually make that impact on the NHS that we want to. Throwing more money at the NHS is not going to solve the problem, but solving problems like this probably will. And, you know, because I'm an optimist, I do draw the graph and I kind of figure out when that's going to happen. And, you know, if this trend continues, it's going to be around about 2050, hopefully, that we will sort of reach that target where these cancers are sort of minimised. Right, what about breast cancer? So breast cancer has some drugs where they've done clinical trials. This is a prevention trial where they treated with one drug, anastrozole, versus placebo, without the drug, in 4,000 people. They treat them for 5 years, and then they follow them up for 12 years and find out who got breast cancer and who didn't. And those that took the drug, breast cancer was reduced by half, actually. So if you take that drug, you're dropping your risk by 50%. And that's a pretty good decrease in breast cancer. In total, it would probably decrease about 15,000 cases per year if everybody did this. But there's a problem with this, because in 2013, the guidelines, these are the NICE guidelines that recommend the treatment that doctors can prescribe, they sort of recommended tamoxifen and another drug for this prevention. Not many GPs were even aware of this, and not many prescribe it. And yes, I spoke to some GPs last night, we were discussing this, and there are other factors about monitoring these drugs and various other things. But one of the key problems is that it's off-licence. And so even when this drug came out and NICE recommended that this drug was used, uptake of that was slow as well. And so it was this off-licence problem that they had to solve. And it was only last year in November that they did solve this. Let me just... All right. So now it's licensed for this indication. So you can prescribe anastrozole for chemoprevention of breast cancer for women who are either moderate to high risk. And then it comes a question, how do you work out whether they're moderate or high risk? But there are ways of doing that. What about ovarian cancer? Can we prevent ovarian cancer? This is some data from a study from Val Beryl and others in Oxford. And it shows this particular drug, I mentioned it earlier. If you take this drug for 10 years of your life, it doesn't matter when you take it, it can be from 15 to 25 or 20 to 30, your risk of ovarian cancer is reduced by half if you take it for 10 years. And this is the combined oral contraceptive pill. So if you've taken that pill for any period in your life, it will be contributing to reducing your risk of ovarian cancer. So it can actually prevent ovarian cancer. Now, there's complications here as well because, going back to that Daily Mail list, COCP does actually increase your risk of breast cancer. But when you're in that young age group, 25 to 30 or something like that, your absolute risk of breast cancer is quite low. So, you're balancing risk and benefit here. So I think as a chemopreventive agent, it looks pretty good. So there's research in my lab going on at the moment trying to understand, how does this work? How does it actually prevent ovarian cancer? If we can work that out, maybe we can come up with other drugs that can do the same thing and prevent ovarian cancer without having to give people the oral contraceptive pill. So we've been working on that for a few years now. Now, here's the major success story. This is absolutely amazing. I hope you already all know about this. But you might be aware that in 2008, the UK introduced the HPV vaccine. HPV is a virus. It causes cervical cancer. Almost 99% of cervical cancers are caused by HPV. And so this vaccine was given to girls 12 to 13, thereabouts, in 2008. There was a second generation that targets more types of HPV now. That was introduced. And in 2019, they finally acknowledged that boys can get HPV cancers as well, and they've started to vaccinate them as well. And the prediction is that cervical cancer is going to be pretty much eradicated by 2040. That's pretty amazing. We've taken a cancer that kills a lot of people, and I'm sure you probably remember, those of you old enough to remember things like Jade Goody and, stories like that of people that have died from cervical cancer. And it's a really nasty disease when it starts to metastasize. And I won't show you any of the data on this, but I thought I'd show you the quotes, because I think, this really just tells the story. Peter Sassini from King's College, he published this paper in The Lancet in 2021, where they're saying the HPV immunisation program has successfully almost eliminated cervical cancer in women if they were born after 1995. So for anyone born after that, you're never going to see cervical cancer. And that is absolutely fantastic. There was a study that just came out a couple of months ago in Scotland that said there have been no cases of cervical cancer detected in young women who have been fully vaccinated. No, none. And that's incredible. And so it sort of led Amanda Pritchard, she's the NHS chief executive, to say the NHS has made this truly momentous pledge to eliminate cervical cancer by 2040. And I actually think it's achievable. So, set your clocks for 2040 and keep an eye on it, because I think it's going to happen. Now, I feel it's kind of important to also remind you all that for women who have not been vaccinated, and I'm sure there are plenty here, it's also really important to continue your regular screening for cervical cancer. You'll get a letter in the mail from the NHS saying it's time for your screening. Don't ignore that. Go and do it, because it's really important still. Right, so let's move to earlier diagnosis. One of the biggest things in earlier diagnosis in the last, let's say, 2 to 3, 5 years maximum, has been these things called MCEDs. Now, that's an acronym. That's an acronym for something called a multi-cancer early detection test. This is a test that people are developing that's going to pick up any cancer type in a single blood sample. Or, you might monitor it over several blood samples and see how it's changing. And just to explain how it works, it's also described as what they call liquid biopsy. So you take a blood sample. Imagine you've got a tumour. This is a picture of a tumour. It's got its blood vessels. And every now and then, cancer cells slip out into the blood system. And they'll start moving around the body. And that's how cancer cells metastasize. If those cells land somewhere that's safe for them to land, they might metastasize and spread. More often than not, though, those cells die. They'll die in the bloodstream, and they'll break down, and the DNA from them will start floating around in your blood. And so we can take that blood out of your, a small blood sample, spin it down, take the plasma sample, which is the yellow stuff here, and there's DNA floating around in that. And we can look for cancer-causing mutations or cancer-causing changes in DNA and detect that you've got a cancer somewhere in your body. Now, the most famous of these tests is one called Gallery test. It's from a company called So they're detecting cancer DNA, but they're also able to use that DNA to work out where that DNA is coming from in the body. So they can work out whether it's coming from a liver tissue or breast tissue or colon tissue or whatever tissue type, it can work it out. So they claim that they can identify up to 50 cancer types. But there is still a little bit of uncertainty with this test. These are the key questions. So the first one is, how much earlier can you actually detect this compared to normal diagnosis? Is it really going to get you, if you say, oh, this test can actually detect that cancer about a week before you otherwise would have been diagnosed, it wouldn't make much difference to your cancer treatment. But if it's a month earlier, 6 months earlier, 3 years earlier, that would make a big difference. We don't know the answer to this question yet. How many people without cancer also have detectable DNA in their blood? This is also true. We can see DNA in people who don't have cancer. So this is really about the false positive rate. So imagine we do the test and we find that you've got DNA that looks like it could be cancer. We then go and do all of these follow-up tests. Those follow-up tests cost money and, of course, also the anxiety of telling someone they might have cancer, all of that. So this false positive rate needs to be as low as possible, and at the moment it's not. The last question here is, how many people with cancer do not have detectable DNA? This is the false negative rate. How many people do you do this test in and say, get out of here, you don't have anything? And then subsequently they get diagnosed with cancer. Then that test was pretty rubbish because it didn't pick it up. And this is really the biggest challenge for this test, because there's a lot of patients that don't have that. So I don't think it's ever going to be the only test you get for cancer, but it might help as part of a battery of tests. And really, to test this, the NHS has really gone all out on this test. They think this is fantastic. They've started a clinical trial called the Gallery trial, where they've got 140,000 people in the UK, and they're going to be testing this particular test over several appointments. And then they're going to be following them up and seeing who gets cancer and who doesn't, who gets diagnosed or not. And those results, this test, the trial only started 2 or 3 years ago. They're expecting the results this year, or maybe early next year. And they've already committed, the NHS have already said, if the results of this test are positive enough, we're going to roll it out to a bigger study of 1 million people. And we're going to then test it again. I actually spoke to one of the guys in the NHS who's making that decision on, is this test good enough? And they've set the bar really high. This test has to be really good before the NHS spends all that money on this. It's pretty expensive. So, the NHS is being very careful about this. But if you happen to want to do this test yourself, just nip over to the US, because you can buy it yourself over there. That's the way the US medical system works. You can pretty much buy what you like. And I think they're already selling it over there. Right, next topic. This is digital health and data donation. This is an area that I've been doing a lot of work in for the last 5 years, and this is all about big data. And when I think about big data with other people doing this research, we're looking at the sort of data that's out there that we can use for early detection of cancer. Things like shopping data, wearable devices, electronic health records, CCTV, watching where people move, financial data, phone data. All of these things are data types that can potentially help us in diagnosing cancer earlier. And I just want to tell you about clocks. Clocks is a study that I'm the PI for, and we've been doing this since 2019. And I'll just start with this picture of Fiona. She's our patient representative. She's had ovarian cancer. She was diagnosed on her 25th birthday, which is pretty young for ovarian cancer. And you're probably not surprised, it came as a complete shock. One of her symptoms was acid reflux. And she kept telling us she could not leave the house for about 2 years without antacids in her bag. With that, and along with some of our other ideas, we kind of started wondering, what if we can identify a change in purchase behaviour in your shopping data that might indicate self-medication of cancer symptoms? And what if we can detect that much earlier than when you would otherwise go to the GP? So I'm not going to go through all of the data of this, but I'll just give you the headline figure. We ended up recruiting 153 ovarian cancer patients where we could look at their shopping data from 2 high street retailers. I can probably tell you who they are. When we published the study, we had to call them high street retailer 1 and 2 because they didn't want to be named. But basically what this graph shows is we're looking at pain and indigestion medications, and we've lined up our cancer patients at their diagnosis date here and the matched controls to the same period, and we're looking backwards to the 2 years before they were diagnosed. And what we see is the pain medication and indigestion medication is really high, up close to their diagnosis, and it actually started going high. They're buying about 3 times as much as the control participants around about 8 months before their diagnosis. So, if we think about that, we also did a questionnaire with this so we can ask some questions of our patients. So we've got them buying products 8 months before their diagnosis. We asked them, when do you first remember having symptoms? And on average, that's about 4.5 months. When do you remember your first GP visit with those symptoms? That happens about 3.5 months before their diagnosis. And many patients go through multiple GP visits before they eventually get that referral. So we've got a period of time here, 4 or 5 months, where the data is indicating something that we might be able to use as a little nudge and say, maybe you should go and talk to your GP about that symptom. And that might get you into that pathway sooner and might get your diagnosis 6 months earlier. For an ovarian cancer patient, that could be huge. That makes a big difference to their outcome. This study was published a bit over a year ago. We got a lot of media attention. There was a lot of BBC, Guardian. You probably can't tell, that's the Daily Mail there. That's my favourite one. We've been awarded the Data IQ Awards last year. We were on, there was a documentary that was on Channel 5 earlier this year. So there's a lot of interest in this research. CRUK are also still interested. They've funded us to continue. And we're going to be continuing this now, expanding up to 10 different cancer types. So over the next 3 years, we're going to get some answers about other cancers like pancreatic cancer, colon cancer, esophageal cancer. So we're going to be looking at that soon. Right, so where are we up to? Better treatments and better outcomes. So let's come back to this graph, the hallmarks of cancer. One of the biggest changes, I guess over the last 20 years, let's say, is this idea of precision medicine, personalised medicine, getting drugs that treat your cancer with the mutations that are detectable in your cancer. With all these hallmarks, we've got drug targets targeting all of these things. And this is just a small list. This is kind of the granddaddy of molecular targeted therapies, imatinib. For leukemia, that was kind of approved around about 2003. We've got other drugs, the PARP inhibitors for breast cancer, prostate cancer. This is for anyone that's got a BRCA1 or BRCA2 mutation in their tumour or a hereditary mutation. These drugs are really specific for that particular mutation. These are only just recently approved as well. So we've got a lot of new drugs that are coming along, and all of these are having an impact. They've all been approved because the clinical trials showed that they do make an impact. And the biggest thing, I guess, most recently, you may or may not have heard of this, is the idea of immunotherapy. Now, there's lots of flavours of immunotherapy. This is just one of them, where what we're doing is we take blood from the patient, and we take the T cells, this is one of the effector cells of the immune system, and we train it. We reprogram your T cells so that they can recognise cancer. And we can train it either by genetic engineering, or we can train it with drugs, and we can push it in a direction, and then we expand that population, and then we stick it back in. And then those cells run around your body and they target the cancer cells. And the clinical trials for this have been remarkable. Like I've seen melanoma clinical trials for immunotherapy that basically wipe out the melanoma. I remember a clinical trial that stopped early because they had no complete response in the patients that were treated with the drug compared to the others. And they just said, look, we don't need to keep doing this trial any longer. It's already working. You can see this number here. There's over 1,000 clinical trials. Okay, this is a little bit old. In 33 different cancer types testing this particular type of immunotherapy. So there's a lot of interest, there's a lot of excitement about this area, and I'm sure as these therapies become more mainstream, you're going to hear more about it. And finally, coming back to better outcomes. So I kind of started with this 50% figure here. This is where we're at the moment. So if you were diagnosed around about 2010, the data in 2020 So 10-year survival tells us that about 50% of patients are meeting that 10-year survival. And you can see the steady progress from the 1970s up to here. I thought I'd just put numbers on this to give you an idea of how many cancer patients have been making it to that 10-year each year, or each decade, sorry. So over that 50-year period, we've now got nearly 100,000 people more that are surviving to 10 years. So that's great. But better outcomes isn't all about survival. I'm sure anyone here with cancer, or if you know someone with cancer, it's not just about survival, it's also about quality of life now. And I think this is one of the big changes I've seen in the last, let's say, 5 years or so, that we're starting to really not only think about quality of life, but measure it. And this is a study called the Cancer Quality of Life Survey. They're aiming to get about 200,000 cancer patients each year, or people, I should say, not just cancer patients. They want healthy participants joining this as well, to monitor over time how quality of life changes. So things, okay, you probably can't see these. These are all various health metrics that you can measure. We want to see treatments getting better. We want to see people surviving better and having better quality of life while they're being treated for cancer. That's, I think, something that we need to do more work in to understand it. Right. Tomorrow, let's have a look. So we're going to ask Zoltan to look into his crystal ball and tell us what are some of the things that are coming up in the future. So a cancer vaccine. The COVID pandemic taught us very quickly that the mRNA vaccine that they made could be developed really quickly and rolled out really quickly. And the people in Oxford are now actually turning that technology to cancer, and they've just been awarded a very large grant to develop the first mRNA-based vaccine for lung cancer. So over the next few years, we're going to see if that works. If that works, it might work for other cancers too. So it might be possible that, in the years to come, that we might have a vaccine for cancers. We'll know soon enough. Gene editing. So I mentioned with the immunotherapy that we can actually take cells out of the body, use gene editing on those cells to train those cells to be able to hit cancer better. There's going to be a lot more of that soon. I didn't talk much about AI. AI is a big thing in medical AI. I know in the writing field, AI is a bit of a dirty word. AI covers and AI books flooding Amazon, all of that. But in science, in medicine, there's a lot of companies that are developing AIs that can screen mammograms, for instance. So any of the women that have gone and done your mammography, you've got a radiologist looking at that picture, trying to decide whether you've got cancer or not. The AI is now doing it better, actually. And so it's probably not going to be long before the AI is going to be the primary screen for mammography. And it'll probably make it quicker. It's going to put radiologists out of a job. But hopefully it'll get you to your diagnosis and treatment quicker as well. And that's really the key. That's the advantage of getting AI involved in these things. Lollipops. This is a study that's going to be looking at using lollipops that you suck on and then you stick it in a machine and see if it changes colour. That lollipop's going to pick up a protein that comes from mouth cancers, and if it changes colour, you've got that protein as a biomarker. It's a pretty neat little trick. Everybody's used to going to maybe when you were younger, going to the doctors and getting a lollipop. When you're older, you're going to be doing the same thing. What about smart toilets? Smart toilets to detect cancer. Imagine we can use urine samples to detect bladder cancer, or poo to detect colon cancer. Anyone here who's done the FIT test for colon cancer screening, you will know how it works. What if you can just do it, you install a device in your toilet and it just measures it every day? And that way, as soon as that changes, you can go to the doctor and get a diagnosis sooner. I've got a colleague of mine at Imperial College that's working on an area around this topic. And I think that's kind of an exciting idea, but a little bit weird. Right. Can we eradicate cancer in future? I believe prevention's the number one way we're going to do that. So I really believe that we've got to prevent as many cancers as we can. That's how we're going to get rid of it. I don't think we're going to treat our way out of this disease. Can we make cancer a survivable minor ailment? You know, you've got cancer, here, take a pill, the magic silver bullet treatment. It'll go away in a couple of weeks. That kind of idea, you know, we're already starting to hope that we can get to a point where cancer becomes a chronic illness, not a death sentence. So, you know, we get to the chronic illness stage, and then beyond that, it becomes a minor ailment. If we can treat it well enough, that's what it'll become. Can we solve the problems in the NHS to help cancer patients sooner? I say, alas, that's not my problem. I can't fix that one as a scientist, but, you know, we can all do our bit, I guess, to help the NHS however we can. I guess voting in the election is probably going to help that. I'll say no more. Can we use gene editing to eliminate hereditary cancers? Well, possibly, but there's a lot of ethics involved in that that we need to come to grips with. And that kind of leads me very smoothly onto my book. I've published my book in September last year. This is called Gene Fire. It's about a PhD student, Larry Milton, who he kind of feels like, you know, the world's going to end if he doesn't finish his PhD. And in fact, it's actually true, because he discovers this dire warning about the Earth's destruction written in the DNA of a young girl as part of his study. He believes this immediately. This is the most fantastic result in his PhD. And his supervisor pours cold water on it and says, "You made it up." And so he sets about trying to convince everybody that it's real. It's won a couple of awards so far, getting really good reviews on Amazon. It was a part of a contest called SPSFC, where one of the judges said it was almost had me shouting out loud at how jammy he'd been. I don't know what jammy means, but the context is probably good. Maybe someone can tell me later. And this one I particularly, you know, they say don't read your reviews. I'm sure everybody has heard that. Is it time? You can totally tell this author's nerding out. And I'm just going to finish with this then. This is the premise. What if we could write in DNA? And you know what they say, show, don't tell. This is the protein coding wheel, and this is some DNA. This one here, that's histidine. This codon, alanine, proline, tyrosine. That's glutamic acid. Go figure, it's an E. Alanine, serine, threonine, glutamic acid, and arginine. Happy Easter. Thank you for the invite. And I don't know, do we have time for questions?
I think we don't have time for Q&A, but I'm sure if people find you in the dealer's room...
I'll be in the dealer's room if anyone wants that book.
Thank you again, Jane Flanagan.